Hello, everyone, and welcome to the webinar. Okay, so let's get started. So about myself, I'm Dr. Aashna Verma, and I have cleared my MRCPCH theory in 2023, all the three parts, FOP-TAS and AKP. And I have cleared my clinical exam in 2024, that is this year, in the month of February. So I'm a recent pass out, and whatever hardship and whatever confusions you guys are going through, I have gone through all that, and I can easily relate to your queries, your confusions, and let's solve it all together. Okay, right. So currently I'm a mentor for MRCPCH Part 1 preparation with MedExam Expert. Okay. So about the exam, about MRCPCH. So basically it is membership of Royal College of Pediatrics and Child Health, as we all know. It is a prestigious qualification for pediatricians across the globe, okay? And it plays a significant role definitely in the career development. Now, what is special about this exam is that, having given all the theory exams and all the, clinical exams and all the station in the clinical exam, you undergo a rigorous assessment process, whereby they assess your clinical skills and competencies in managing pediatric patients. So you have to be clear with your basics and your application part of your knowledge, and also the practicals, right? Okay. Now about the exam and about the different parts which this exam comprises. So you have to go through part 1, which comprises of foundation of practice and theory and science. Okay, so these are two exams, two different kind of exams which make part 1 of MRCPCH. Then we have applied knowledge in practice, which is part 2 of MRCPCH, and it has been named as part 1 and part 2 based on the type of questions and advancement in the question that they ask. But you can take part 1 before taking part 2, or you can take part 2 before going for part 1. So you can decide that for yourself. For a newbie, I would recommend them to go for part 1 and then part 2. But if someone is sure about their application part more, someone who has been practicing and has been away from studies, maybe they can decide to take part 2 before taking part 1. Okay, so that's a decision that an individual has to take call upon. Okay, and about when are these exams conducted? So part 1 exam is conducted in the month of Feb, June, and October. Okay, and also to specify the fact that part 1 exam, which comprises of FOP and TAS, can be sat separately. By that I mean, if you want to go for FOP of part 1 separately and then sit for FOP of TAS exam separately, you can do that. Okay, it's not compulsory to give FOP and TAS together, right? Okay, so yes, it is conducted thrice a year, that is in the month of Feb, June, and October. And part 2 exam, that is AKP exam, is conducted thrice a year, which is in the month of Jan, May, and September. Okay, right. And about the clinical exam. So clinical exam is the one that you sit only after you have cleared all your theory exams. Okay, so here we cannot change the sequence. You have to clear part 1 and part 2, and then only appear for clinical exam. Okay, right. Okay. So about the exam format, what is different about FOP? What is different about TAS and AKP? So in TAS, they basically assess your basic scientific knowledge about anatomy, physiology, pharmacology, and pathology. Okay, so they are trying to assess your basics that we have learned in our medical school in the initial few years. This is what they want to assess, but it would be related to our subject, that is pediatrics. Okay, then about FOP. FOP, it assesses our clinical and applied knowledge, understanding, and decision-making skill. So what FOP does is it gives you clinical scenarios, and then it tries, it wants you to relate that clinical scenario with the basic knowledge that you have about the pathology, physiology, pharmacology, and basic pediatric application part. So it is it basically assesses your clinical knowledge. Okay, then come to AKP. AKP, like FOP, will again assess your applied and clinical knowledge, but it would be more advanced. The questions being asked would have 2 to 3 parts within it, and then you will come to the conclusion. For example, for a question of AKP, will give you a clinical scenario, so and so is the patient, this is the presentation, okay, and then you went for these investigations, right? And now you have to tell them what would be the first line in the management, okay? And also sometimes they ask to you about the definitive management or definitive treatment or a medication, okay? And sometimes they do ask you about the investigations as well. So it is basically an advanced, form of questions that are asked in FOP, okay? Right. So all these exams that are the theory exams are computer-based, conducted thrice a year, and they are conducted in 2 different settings. Suppose if you are going for your part 1 exam and you're sitting for FOP and TAs together, then the FOP would be conducted in the morning and TAs would be conducted in the afternoon session. Similarly, for part 2 exam, when you go for the exam, AKP part 1 would be conducted during the morning, and AKP part 2 would be conducted in the evening, okay? And yes, AKP also has 2 parts, but there is no choice of going for it separately. The exam itself is conducted in 2 different settings, is the thing. Okay. Okay, right. Now talking about the clinical exam, as I told you, we can sit for it only once we are done with our theory exams. And it is, advisable to have 2 to 2.5 years of experience in pediatrics before going for this exam. Okay, and mind you, I said advisable. Okay, I'm not saying it is compulsory. They would not ask you for any proof of you having done practice in pediatrics anywhere. And if you have done lesser than that, they won't stop you from going for the exam. But it is advisable by the RCPCH to have some years of experience in pediatrics before you go for the clinical exam, because the clinical exam has been set in such a way that you need to have that for clearing the exam, right? So you need strong clinical skills in real life pediatric patient exposure. The way you talk to them, the way you examine a pediatric patient is very specific and very subtle. You cannot treat kids as small adults. So that's why they have advised this thing of having experience in pediatrics before going for the exam. So again, the clinical exam is conducted in 3 days in UK, but in overseas, it is, it depends upon the country. In most of the countries, it is conducted twice a year. Okay, right. Now, talking about the waiting period of clinical exam. So for those who have given their theory exam and are appearing for clinical exam, have to undergo waiting period of 6 months to 1 year, and in some countries even 2 years, because of the fact that COVID was there and the clinical exams couldn't be conducted in that time. There is quite, period of waiting there in most of the countries. Okay. So yes, that is about the waiting period. And about the preparation. So preparation usually, it takes 6 months to 1 year to prepare for the clinical exam. Okay. And yes, it is actually the toughest of all. Okay. Yeah. And definitely you need to have consistent practice, and it is advisable to have a partner or a group to study with, okay? So why MRCPCH? Okay, why? What is the hype all about? Okay, so yeah, let's see. So it gives you professional recognition. Okay, it signifies a high standard of knowledge and competency in pediatrics. As I told you, that you have to undergo, rigorous assessment, which comprises of basic theory knowledge, advanced clinical skills, and how you approach a patient. When you give this exam and when you prepare for this exam, you yourself would feel the difference in um, in the level that you started with and the level that you have reached after going through preparation of this exam. Okay, and it definitely enhances a pediatrician's CV and professional profile. Okay. Then about the career advancement, yes, it enables pediatrician to apply for senior post. Okay, and it definitely enhances knowledge and skills because it covers a wide range of pediatric topics, and it ensures that you have thorough understanding of child health. Now about theory knowledge and practical skills. As I said, you have to have good theory and good practical skill to be MRCPCH, to have cleared MRCPCH. Okay, about global recognition, yes, this exam is, this degree is valid globally, okay? And it is recognized in most of the countries across the world. And it provides access to a global network of pediatric professionals, yes. Continuing professional development, once you have given MRCPCH and you get connected to the RCPCH, you can have access to their ongoing educational resources, including their journals and their workshops, which is provided by the RCPCH. Okay, right. And yes, about the research in academia, this exam makes sure that you have good knowledge about research skill and statistics, so that once you have given this exam, you can be into different research opportunities. You can avail those opportunities and get involved in research projects and academic roles. Okay, right. And yes, you can apply for teaching position, and you can contribute to the healthcare qualities after having undergone through this exam. So pathway to UK, yes, this exam is pathway to UK. For you to practice in UK as a pediatrician, you have to give this exam, okay? And once you are done with all the parts of it, you go for English proficiency test, that is OET and IELTS, and with that you get registered into the GMC, that is General Medical Council of UK, and you get registered as fully registered medical practitioner. And with this, you can practice as a registrar in the NHS system, okay, in the NHS health system. So, yes, that is about, how it helps you get into the health system of UK. But definitely, you won't be able to practice as an independent consultant in UK just by having passed this exam. You have to have passed this exam and have some years of experience there. Then only you can practice as a consultant in UK. Okay. So talking about MRCPCH part 1, okay, because this is the first part and the most confusing part, and this is the part where most of us fumble with or get hesitated with, because it is all new to us. Okay, so how to prepare for FOP and TAs? So understand the fact that you have to study pediatrics thoroughly to be a good pediatrician and have good knowledge in pediatrics. Okay, you have to have, like we do in our training days, that we have to study our books thoroughly, have our concepts clear, and so on and so forth. But talking about this particular exam, when you have limited amount of time with you, okay, because most of us are practicing, some of us have family, and with all the hustle in the life preparing for this exam, you need to be very clear and very focused. Okay, you need to know how the exam is being conducted and what is being asked. Okay, so that you do not get lost in the vast ocean of knowledge of pediatrics. Okay, you can keep on studying endlessly, but when you go for this exam or any exam, you need to know that what is being asked, what you have to focus upon, and what all things you have to leave. Okay, you cannot just go on reading and reading and reading. So first and the foremost thing is have strong intention. Most of us fail here. We are not able to have that mindset that yes, I'll give this exam, yes, I'll clear this exam. Okay, most of us take a long period of time to decide whether to give or not. Okay, so first and the foremost thing is have strong intention. Okay, and that is very important, and that is what helps you throughout your preparation. And it's not easy. You have to be mentally strong. It is definitely a mind game as well. So first thing that, and the second thing is know your exam. Okay, know your exam. By that I mean to say that you need to know what RCPCH wants to know from you, or what they want you to know. Okay, and by doing that, you can prioritize things, you can prioritize topics, and this way you can make your study efficient and simpler and easy to revise. Okay, so know your exam well, identify high yielding topics and pattern recognition. Okay, so every exam, be it MRCPCH or any other competitive exam being conducted throughout the world, they like to focus upon some topics, okay, which are important for them. For example, if it is about food allergy or celiac disease in UK, these cases, when they are very common in their health setup, they would definitely include such questions in the exam. Why? Because they want you to have knowledge about it. They want to assess if you know about it or not. Or if you come to their health system, if such case comes, will you be able to be in a position to treat them, to take decisions or not? Okay. So this is the basic funda, that there are some high yielding topics which are also important in the actual practice. Okay, so we have to identify such topics and pattern recognition. By that I mean what kind of questions are being, or what kind of topics are being repeated in the exam. Those are the ones which we have to focus upon more. I'm not telling you to not read the entire thing. You can do that. But when you have limited time, when you are focused towards giving this exam, you just cannot go about it without knowing the high yielding topics, and without focusing more upon it, having in-depth knowledge about it. Okay, and then the important thing is to make notes. Okay, because it is important to revise. If you start your preparation, suppose 6 months before your exam, for a thing that you have read maybe 6 months before giving the exam, you need to revise it at least 2 to 3 times before going for the exam, before sitting for the exam. It helps you tick off answers fast. And the confusion that we have while sitting in front of the computer marking the multiple choice questions, that thing also we have to be quick with it, because it is time limited. So when you make notes, when you revise them, you are more clear and more confident in your mind, and that helps you while marking answers during the exam. Okay, so it is advisable to make notes and revise them at least 2 to 3 times before going for the exam. Okay, and about duration of preparation, so this is a thing which is a little subjective. For some it takes 6 months, for some it takes 4 months, and also it's I'm not recommending this, but I have known people who have even cleared this exam in 2 months. Okay, with 2 months of preparation. So it is, it's definitely doable exam. It is not very difficult exam, but yes, you need to be, focused. You need to know how to prepare, what to prepare, and you need to have constant practice of the kind of questions that are being asked. So about the resources for FOP, we have clinical cases for MRCPCH, Foundation of Practice, which is given by the RCPCH themselves, okay? And it comprises of 50 beautiful questions, beautifully framed questions. And then when you look at the explanation given behind them, you are just clear with, the entire concept, which is being assessed in the question, okay? So it is a very good book. It is basically, 50 questions and their explanations, okay? Then we have Science of Pediatrics. Again, it is given by RCPCH, and it is my go-to book. I made that as my core book for this exam, and it was really helpful. That this book is really a must-do from my side, okay? And then we have Illustrated Textbook of Pediatrics, which is again a very good book for FOP and also TES. So yes, that. Apart from that, we have pediatric guidelines, neonatal guidelines, NICE guidelines, RCPCH sample papers, past recalls, and past tests, which are important, useful resources for FOP. Okay, and yes, this is not just the only list. You can include a lot of other things in your preparation. I'm not saying no to that, but these are the ones which are of utmost importance, and these are the ones that I went for while preparing for my exam. Okay. Moving on to useful resources for TES, we have clinical cases for MRCPCH theory and science. Again, it comprises of 50 questions, and with after every question, you have explanation for the given question, which beautifully covers the entire topic that is being asked in the question. Okay. Then we have Science of Pediatrics. Again, this is the same book that I talked about for FOP. It is good for the entire Part 1 exam. It helps you with both FOP and TS preparation. Then we have RCPCH sample papers, past recalls, and some files that are pharmacology, ethic files, and statistic files, which we have in our study material in MedExam Expert, and it is also being circulated online by helpful people across countries. Okay, right. Then what are the tips and tricks? So as I told you, it is important to make notes and read notes. Okay, then focus on high-yielding topics. As I'm saying this repeatedly, you need to prioritize your topics, your area of study. Okay, and don't forget the importance of revision. Revision is very important before you go for the exam. And there you need to strike balance between reading and solving questions. How do you do that? See, during your initial part of preparation, that is first half of the preparation, it is advisable to have a good reading and concept building in the first half of the preparation. Whereas in the second half of preparation, I would want you to divide it 50-50% between reading content and solving question. Okay, I hope it is clear to you what I mean to say. In the second half of preparation, I want you to solve more questions. Okay, because it gives you idea of how are the questions being formed, and how to apply the content that you have already built up in your mind, how to apply it, and how to assess yourself, like where are you going wrong, what are you doing correct. You need to know these things before you sit for your exam. And then manage your time well, definitely during your preparation also, and while solving the while giving the exam also. Recalls are must do. Okay, recalls are basically previous year's questions, which the candidates who have appeared for the exam have been able to recall, and help us with these questions. So these previous year's questions are, very important to solve and very important to, go through before sitting for the exam, because the exam has tendency to, repeat the questions, which I call as high yielding topics. Okay, they repeat not exactly the questions, but yes, the topic is being repeated. The high yielding topics are being repeated. So to know these, you need to go through the recalls. Okay, identify your weak areas and supplement that with more reading. Okay. Now, about the recalls, which I talked about just now, which are previous year's questions, they are definitely must do. And you should do it only in the second half of your preparation, because I do not want that you start your preparation with recalls, because that will, that won't let you clear your concept, and that won't help you build up the kind of content which you need to have before going for the exams. You might get limited to just the kind of questions being asked, but remember this, they do not most of the times repeat the question, but they repeat the topic. So you need to know the topic in and out, the ones which are being assessed frequently. Okay, so it is advisable to go for recalls in the second or the later half of your preparation, and these are available topic wise and year wise. Okay, we have both kind of recalls available with our RCPC or with our med exam expert study material. And yeah, the recalls, it is important to know that they are a little different from the actual exam question. Now, how are they different? So recalls are, kind of shorter questions. When you tell me, when you ask me what question was asked, I'll be able to pick up the keywords that I remember, which help me to come to the answer. Okay, but in the real exam, the question is little more lengthier. Okay, because it consists of some information which is not helpful or which are distractors. Okay, so when I come and when I tell you that this was the question, I won't be remembering those information which did not help me come to the answer. Okay, I'll remember the keywords which help me, find the correct answer. So this way, the recalls are short. They have shorter stem of question, whereas when you sit for the exam, you'll see that the questions are actually lengthier. Okay, it takes time to read the entire question and then mark the answer. So this way, the recalls are different, and yeah, the recall bias definitely does exist. Right way of doing recalls. So yes, recalls, as I told you, help you identify the topics which are favorite of RCPCH, which they want you to know and which they want to assess you for. Okay, so know those topics thoroughly, and know why a particular option which you are marking as correct is correct, and why the other options are not correct. You need to know why they are wrong. Okay, and build up a correlation, proper correlation, and have good concept when you solve recalls. Okay, right. Now let's get started with the topic that I promised you to discuss with this webinar, that is approach to congenital heart disease. Okay, so yes. Okay, this is a very informative flow chart. Okay. So we have two types of congenital heart disease: acyanotic heart disease and cyanotic heart disease. Okay, so there is huge clinical difference between acyanotic and cyanotic heart diseases. First and the foremost thing, how do you classify them, is the fact that acyanotic heart disease, in that the child will be having low saturation, which would be, almost near normal. Okay, it would be more than 90%, 92%. Whereas in cyanotic heart disease, the saturation, saturation would be lesser than 88, 89%. Okay. And apart from that, there are a lot of other clinical differences, like acyanotic heart disease child maybe, maybe just like a normal human being, and maybe the CHD is not diagnosed for a lot of, years. Maybe it is diagnosed incidentally, okay? But yes, in other conditions, there may be, a failure to thrive seen, and there may be, recurrent respiratory tract infection seen, and others acyanotic heart diseases. Whereas in cyanotic heart diseases, you can definitely see features like, cyanosis, you can see clubbing, and based upon if there is increased pulmonary blood flow or decreased pulmonary blood flow, there will be tachypnea seen, there will be repeated LRTI seen. Okay, so these are the basic clinical differences between acyanotic and cyanotic heart diseases. So what do you need to know for your part 1 exam? So I'm basically going according to things that you need to focus as far as your part 1 exam is concerned. So know this table well, know this flow chart well, okay? Acyanotic heart disease, it can have, there can be two scenarios: volume overload and pressure overload, okay? By volume overload, I mean to say that there is more blood being accumulated in a particular chamber of the heart, okay? So there is volume overload of that chamber that is taking place in volume overload type of acyanotic heart disease. Whereas in pressure overload, because of some obstruction or because of, some, difficulty in outflow, there will be pressure buildup, okay? Not really volume of the blood, but there will be pressure buildup during contraction phase of the cardiac cycle, okay? Right. So about volume overload, we have left to right shunt lesions, okay? These left to right shunt lesions include AST, they include VST, and they also include PG. Also, endocardial cushion defect is a kind of left to right shunt, okay? So these are the left to right shunt lesions which have volume overloading seen in them, okay? And right, about pressure overload, there can be two scenarios. Either there can be outflow obstruction or there can be inflow obstruction, okay? With outflow obstruction, based upon where exactly the obstruction has taken place, either it can be at valve in case of valvular pulmonary stenosis, valvular aortic stenosis, and coarctation of aorta. In other conditions, there can be the obstruction can be below or above the valve. For example, in case of subaortic membrane, and it can be above the valve in case of supravalvular aortic stenosis, okay? So this is about outflow obstruction lesion in case of pressure overload. Now, in case of inflow obstruction, we have tricuspid stenosis, mitral stenosis, and core tritrium, okay? These are the inflow obstruction lesions, okay? So this much is usually not assessed for your part 1 exam. You need to be thorough with volume overload lesions and the fundamental of pressure overload lesions in acyanotic heart disease. Talking about cyanotic heart diseases, it can be of two types. There can be two phenomena taking place. Either there can be decrease in the pulmonary blood flow, okay? So the cyanosis is taking place because of decreased pulmonary blood flow, or there can be cyanosis with increased pulmonary blood flow, okay? So decreased pulmonary blood flow is seen in case of tetralogy of Fallot and also tricuspid atresia, okay? These are the two lesions with decreased pulmonary blood flow. And how do you know this clinically, that there is decrease in the pulmonary blood flow? You can know it with the clinical symptoms that most of the times, there is no features of repeated LRTI in most of these conditions. And in the chest X-ray as well, there is clear, lung field seen. Whereas in case of increased pulmonary blood flow, there will be pulmonary plethora seen in the chest X-ray. there will be tachypnea seen, okay? There will be tachypnea seen in this condition, and definitely there can be repeated LRTI episodes seen in such patients, okay? So with increased blood flow, cyanotic CHD, we have TGA, TAPVC, tricuspid atrasia, and hypoplastic left heart syndrome, okay? So this is the basic flow chart of congenital heart disease, and I would want you to be thorough with this because it forms the basic framework of congenital heart disease in your mind. Okay? Moving on to the types of presentation with congenital heart disease. So different kind of lesion will have different kind of presentation. So this table has been taken from your Science of Pediatrics book, which is given by the MRCPCH, okay? So left to right shunt that we talked about, that consists of AST, VST, and PDA, they basically, they can have asymptomatic presentation, but they can also present with breathing difficulty, they can present with breathlessness, they can present with difficulty in breathing, tachypnea, okay? Whereas those lesions which have right to left shunt, okay, that the blood from the right side of the heart is moving to the left side of the heart. So that means the deoxygenated blood is mixing with the oxygenated blood. That basically, that basically causes cyanosis or decrease in the overall saturation of the body. So the symptoms would be blue. That means there would be cyanosis. Okay, and the example for this is tetralogy of Fallot and TGA. Okay, they have right to left shunt seen in them. Then talking about the common mixing lesions, they present with breathlessness and they also may have cyanosis seen in them. If the example being AVSD, complex congenital heart disease. Okay, and a well child with obstruction. Okay, so any child who has a good growth but has murmur present in them. So they can be, the ones with obstruction having conditions like aortic stenosis or pulmonary stenosis or other type of coarctation of the aorta. These are usually diagnosed late or diagnosed incidentally, and most of the time the patients are asymptomatic. Okay. Then we have sick neonate with obstruction. We have those lesions which cause collapse of the systemic circulation, which cause shock. Okay, so the conditions are neonatal type of coarctation of aorta and HLHS syndrome. Okay. Okay. Now talking about left to right shunt, we have AST, VST, PDA. AST can be secondum type, it can be partial AVSD, okay? And most of the time, they are, asymptomatic. What are the signs? How do you know on clinical examination that this can be a ASD case? So on examination, you will be able to hear ejection systolic murmur in the upper left sternal edge, okay? So if you see, if this is the chest, right. So this is the sternum, and this is the rib 1, 2, 3, 4, and 5. So here you get to listen the murmur of ASD, okay? Ejection systolic murmur in the upper left sternal edge, okay? And it is fixed splitting of S2 sound is heard in case of ASD, okay? Whereas in partial AVSD, same, the ejection systolic murmur is heard in the upper left sternal edge, and there is fixed splitting of S2, and there may be pansystolic murmur heard in the apex in cases of partial AVSD. Whereas in VSD, the murmur that is heard in a small VST and a large VST is a little different. And also the clinical presentation in case of large VST, they may present with heart failure, whereas small VST may go unnoticed for some time for initial years. But there will be pansystolic murmur heard in the lower left sternal edge. Okay, so near the fourth and the fifth intercostal space, near the fourth intercostal space, you will get to hear the pansystolic murmur of VST. Okay, and there is active precordium, loud P2, soft murmur, tachypnea, and hepatomegaly seen. Hepatomegaly would be seen in case of heart failure. Then about PDA, it has continuous murmur heard in the upper left sternal edge with bounding pulse. So here you can hear the PDA continuous murmur or machinery murmur that we call as, that it is called as, and with that you can feel bounding pulses in the peripheral pulses. So moving on to the next slide. Cyanotic congenital heart diseases. First, we have tetralogy of Fallot, which has loud murmur in the left upper sternal edge. Okay, and that is also ejection systolic type of murmur. And in case of tetralogy of Fallot, the murmur is basically of the right ventricular outflow tract obstruction. So the pulmonary stenosis that is seen in TOF is what causes the loudest murmur which is being heard in case of TOF. Okay, then there is clubbing of fingers and toes. There is hypercyanotic spells seen. Okay, in transposition of great arteries, which is another kind of congenital heart disease, there is a neonatal cyanosis seen, and it usually presents early in the neonatal period. And in this condition, there is no murmur seen. So if you get any question in the exam which says there is no murmur heard, but there is early cyanosis seen in the newborn, then definitely they're talking about transposition of great arteries. Okay. Then Eisenmenger syndrome, there is no murmur heard in this condition as well, and there is right heart failure seen, but it presents little late. About TGA, TGA develops due to defect in the migration of the endocardial cushion. Okay, this question has been asked in one of your TS exam. Okay, so this was a previous year question. Okay. Right. Okay, now let's move on to the next slide. Right. So this is an image of tetralogy of Fallot, and here we have four components, four definitive components which make TOF. Okay, so the first thing is narrowing of the pulmonary wall. Okay, so here you can see narrowing of pulmonary wall, which is an important component in TOF. Okay, and this is the one that decides the severity of TOF. Right, so this right ventricular outflow tract obstruction or the narrowing of the pulmonary wall is a very important component of very common important component, and also important basically we can say an abnormality which is seen in TOF. Okay, right. Then we have thickening of the wall of the right ventricle, which is right ventricular hypertrophy is seen in TOF. The third abnormality that we see is displacement of the aorta over the ventricular septal defect, of what we call as overriding of aorta, right? And then the fourth abnormality that we see is ventricular septal defect, that is opening between the left and the right ventricle. Okay, but understand the fact that this shunting through the ventricular septal defect is not really what causes the murmur or what gives the murmur in case of TOF. It is the first component, that is right ventricular outflow tract obstruction, that is narrowing of the pulmonary wall, which is giving the murmur, that is ejection systolic murmur heard in TOF in the upper left sternal edge. Okay. Then outflow obstruction in a well child, for a well child, well-grown child. Outflow obstructions are basically aortic stenosis, pulmonary stenosis, and coarctation of aorta of adult type. What kind of murmur we hear in case of aortic stenosis is upper right sternal edge, okay? Upper right sternal edge. Here it is. This is the sternum. So here is the upper right sternal edge, okay? Here you get to hear the murmur of aortic stenosis. And you also get to hear carotid thrill as well in case of aortic stenosis. In pulmonary stenosis, the murmur is heard in the upper left sternal edge, and there's no carotid thrill heard in this condition. Then in case of coarctation of aorta of adult type, there is systemic hypertension seen, and there is radiofemoral delay seen. Okay, right. Then talking about the left heart outflow obstruction in sick child, basically those lesions which are duct dependent. Okay, so there are conditions like coarctation of aorta of newborn type. Okay, this basically presents as a circulatory collapse, and there is absent femoral pulses, shock seen in the child. Okay, so what do we do? How do we manage these duct dependent lesions? With the help of prostaglandin infusion. Okay, so you have to go for basic ABC management, and then you go for prostaglandin infusion. With interruption of aortic arch, which is the second duct dependent lesion, there also you see circulatory collapse, and there is absent femoral pulse and also absent left brachial pulse. This condition is also managed with infusion of prostaglandin. Okay, and with HLHS also, with what we do is prostaglandin infusion, which is the life-saving first line of treatment done in cases of duct-dependent lesions. So remember these names. Okay. And the fact that we go for prostaglandin infusion for these conditions. So what does prostaglandin do is it keeps the duct open. Okay, most of the times it is PDA. It is a PDA which keeps the shunting patent in these kind of duct dependent lesions. Okay, so to keep it patent, we give prostaglandin infusion, which basically helps in keeping the duct open by avoiding the contraction which takes place. And actually this is the prostaglandin which is in fetal life being secreted from the placenta. Okay, and also it is secreted from the lung and the liver, but it is placenta which is secreting these prostaglandins, which is keeping the duct intact, PDA intact. Okay, but once the baby is out, okay, there is a removal of placenta, detachment of placenta, and there is no more provision of prostaglandin to the body, which causes contraction of the duct wall, leading to the closure, which is a normal phenomena in most of the children. But in those who have these lesions, that is coarctation of aorta, interruption of aortic arch, and other duct-dependent lesions, in those kids, you need to keep the duct patent to keep the circulation and connection between the right side of the heart and the left side of the heart and the body. But to keep this circulation intact, you need to keep the duct patent. Okay, so that is the role of prostaglandin. I hope I have cleared your doubt. Going ahead, we have some common mixing lesions like atrioventricular septal defect, okay, which is the most common condition seen in Down syndrome. So in Down syndrome, remember the fact that endocardial cushion defects are the most common lesions seen in this condition. Okay, so that's about Down syndrome. And the common mixing lesion, that is atrioventricular septal defect. It can present as cyanosis at birth and breathless at 2 to 3 weeks of life. Okay. Then we have complex diseases like tricuspid atresia, which are basically, those heart conditions which have more than one component in them. Okay, so there will be tricuspid atresia, there will be shunting lesion seen. Okay, so yeah. Now the important points to remember, which will help you, be able to narrow down to your right answer are these points. Okay, so remember these points. ASD has a splitting of A2, fixed splitting of A2, and there is systolic murmur, as I told you, in the upper left sternal edge. In VSD, there is pansystolic murmur heard in the lower left sternal edge, and it may present with heart failure. Okay, so these are those clinical, hints which will be given to you in the exam. Okay, so, and it is given in this way only. They cannot change the fact. This is the fact. So it is given just in the same words, and with these hints, you will be able to come to the diagnosis of ASD and VSD. Okay. Then in PDA, keywords like continuous murmur or machinery murmur would be seen, and they'll give you hints like a preterm was intubated, and then there is difficulty in weaning off the child from the oxygen support. Okay. So these are the clinical hints given, and also most of the times they, give you question which has premature baby in it. Okay, when they are talking about PDA. Nonetheless, it can happen in term babies as well. In TOF, there will be cyanotic, and they'll mention hypercyanotic spells. In TGA, there will be cyanosis with no murmur. As I told you, whenever you are given a question with cyanosis, which has early neonatal presentation, and there is no murmur, think about TGA. Okay. Then coarctation of aorta, there will be, especially when it is of newborn type, there will be collapse, absent femoral pulses, and what you have to go for is prostaglandin infusion. HLHS, there will be collapse plus absent pulse C. Okay. In PG infusion is given in all outflow obstruction disorders, especially those outflow obstructions which are causing, complete blockage of outflow in cases of neonatal type of coarctation of aorta. Okay. There is another variant, that is adult variant, which is diagnosed later on in the life. We are not talking about that. We are talking about the neonatal type of coarctation of aorta. Then talking about innocent murmur, there was a question once asked about innocent murmur, hence I'm highlighting it here. So innocent murmur can be heard at sometimes, can be heard in almost 30% of the children. Okay, so it can be heard without any pathology as well. It is physiological, and to distinguish innocent murmur from a pathological ones, these are the points you need to remember. So hallmark of innocent ejection murmur are, remember the S's. Okay, it is asymptomatic. That is, there won't be any breathing difficulty, there won't be tachypnea, or there won't be cyanosis. Okay, it has a soft bowing murmur. Okay, there is systolic murmur only. There is no diastolic murmur seen. So innocent murmurs will always have systolic murmur. Okay, remember this fact. Systolic, soft, asymptomatic, and it is heard in the left sternal edge. Okay. It is heard in the left sternal edge, mostly on the upper part of the left sternal edge. Okay. Yeah. Then also the normal heart sound with no added sound. So the pattern of the heart sound will be normal. The S2, S1 will be normal, P2 would be normal. Okay. So there is no alteration in the heart sounds, and there is no added sounds heard in this condition. There is no parasternal thrill heard, and there is no radiation of murmur seen in case of innocent murmur. So these are the points that distinguish innocent murmur or physiological murmur from pathological ones. Okay, right? So talking about murmurs that radiate. So this was also given once in one of the exam, and the question was basically about different congenital heart disease, and the hints were given in form of radiation of murmur. Okay, so whenever you are given at a question that the murmur is radiating to axilla, think about mitral stenosis. Okay, now when you're given the fact that murmur is radiating to back, there are two differentials that you can think about, that is pulmonary stenosis and coarctation of aorta. In pulmonary stenosis, there is radiation at the intervertebral column, okay, in the center. And in coarctation of aorta, there is radiation of murmur to the lower tip of the left scapula, okay. This is the difference between the radiation of murmur between three conditions given, three lesions given, okay. Then yes, this table is about congenital heart diseases seen in different disorders and different chromosomal abnormalities. So it is important to know it, because in some way or the other it is being assessed in your part 1, part 2 and the clinical exam. So it is important to remember the fact that rubella infection has peripheral pulmonary stenosis, and in some condition it has PTA. In SLE, there is complete heart block due to anti-Rho and anti-La antibodies. And in cases of fetal alcohol syndrome, there is AST and VST seen. Whereas in case of Down syndrome, we have aortoventricular septal defect, as I told you. And the second common one is VST. Right. In Turner syndrome, we can see aortic valve stenosis, and also coarctation of aorta is seen in such condition. In chromosome 22q11 deletion, we can see aortic arch abnormalities. In Williams, we can see supravalvular aortic stenosis. And in Noonan, there is hypertrophic cardiomyopathy seen commonly, right? So this was about approach to congenital heart diseases, the basic of it, okay? And as we, discuss it in further sessions, we'll see what kind of questions are asked and how to approach those questions, okay? So yes, any questions are most welcome. I think I have been answering few of the questions in between. So yes, what is the role of prostaglandin? I answered. Can we get recording of this lecture? Okay, thank you, doctor. Thank you, Dr. S. So see, as I told you, pediatrics is very vast, okay? You can keep on reading and reading. So what I have included in this lecture is exactly what you need to know about congenital heart diseases for your MRCPCH exam, okay? And, I could have made it more elaborated by adding on to, incidences and epidemiology, clinical presentation in depth, and there are many more things that I could have included in my presentation, but that is not what I want. I want you to be focused, about any topic in context with the MRCPCH exam. Okay, you need to know what you need to learn for the exam, and that is how we help you with the courses that we conduct. So as I told you, it is important to know the high-yielding topics. It is important to, revise, make notes. So that's what, we help you do. We do the homework of, studying the, high-yielding topics. We do the homework of, making notes and presenting it to you. So that what we give to you is, we make things easier. We give you topics which you have to focus upon, and how much you need to know in a topic, we get it to you in the classes, in the online sessions that we conduct, okay? So, it's important to read efficiently rather than, read more in quantity. It is important to have good quality. Right, there are some questions, I guess. Ma'am, from where we can get recalls? Okay, so you can get recalls. It is available in the online portal. It is also available in our med exam expert content. Okay, we have our website where we have all the PDFs, all the questions, all the recalls, and recorded sessions of our lectures stored there. And Dr. David, you can connect to our coordinators. They'll help you with the recalls. Okay, they'll help you with the link of recalls. Slides were informative, but I have issue with voice. Overall, good experience. I'm sorry, Dr. Atif, for the voice. And okay, right. Thank you for the compliment. Any other queries concerning the topic that we discussed, or any query related to preparation of MRCPCH? You please feel free to ask. Okay. So about our upcoming course, I would want you to know a few things, like we are conducting a new course for our February 2025 session, and the course spans 3.5 months, and it would be an intense course whereby you'll be undergoing you will be having a lot of online sessions and one-to-one interaction with mentors, that is me and Dr. Nida. And the course is starting from 1st of November. Okay, and these are the facilities that would be made available to you in the course. That is 16 live sessions, which will be conducted topic-wise. Like I conducted a part of CVS today, but in the online session, we'll be going through the entire cardiovascular system, respiratory system, and so on and so forth. Okay, you will have recording of the live sessions available to you, so that if you are not able to attend it because of engagement with your work or any other commitments, you can go to it and see it later. Okay, also it will be helpful in this way that what I used to do was I used to attend live sessions, and some days when I did not feel like revising, when I did not feel like doing active learning, I used to just go through those recordings, with into 2 speed. I used to listen to those recordings. So that is, a way of doing passive learning. Okay, you just listen to it, and some things would go into your mind. It is better than wasting, your time. Okay? So that's the importance of recorded sessions. And yes, definitely, whatever we give to you in the live session, those slides, those PDFs would be made available to you. And you'll also have PDF available of the solved recalls. Okay, so the recalls that I talked to you about, which are important part of your exam, we have those recalls solved, and you will be made those available to you. Okay, and about the mock exam, which is a very, very important part in your preparation. That is, when you have prepared enough, when you have solved questions a week or 2 before your exam, I would recommend going for mock exam, which stimulates the real exam, and it helps you get the feel, get your fight, flight, and flight wala hormones activated. So the stress, should be something which you should face once before the actual exam, and not really just in the exam. Okay, because when I went for my first exam, that is part 1, I gave my FOP and TS together. It came as a little surprise to me. I did not, it was a little stressful, the first part. Okay, so yes, mock exam is helpful in this way. It will give you the real exam feel. Okay, and then you have question banks of FOP and TS 5,000 plus questions, okay? So you need not run here and there searching for questions. You will get it all together in the course. And then you will, as I told you, that you need to read few pharmacology, statistics, and ethics PDFs. We have all of them, okay? That will be shared with you. And right, you can feel free to ask questions anytime in the WhatsApp group that is available to you. And, you are given about 10 questions every day in our WhatsApp group, okay, to practice. So that is a very, very good way of keeping consistency in the practice, okay? So even if you solve those questions while, maybe traveling, while just sitting in the cafe, it helps you, keep in touch with the study and the practice of solving questions. So it's very important to keep solving it. And that's what we focus on in our WhatsApp group as well, by posting 10 questions every day. And later on in the later part of the day, we give the solution as well. So this is in-depth features that are being provided in the course that we are going to conduct, okay? And any doubt related to the course, you can contact us. Any doubt related to MRCPCH exam preparation, you can contact me. And also the topic, right? Any more questions? Okay, then. See you all the best. And, may you clear all your exams, all your parts of MRCPCH, and come out with flying colors. Best wishes to all of you. Bye-bye.